Good morning. I hope everyone is having a great day today. I apologize. I just literally got a text message I need to answer. Okay, so today in this lecture, we're going to be talking about pediatric end-of-life care. As you guys know, end-of-life care can be very difficult for the family, for the patient, but when we're talking about peds, it can make it even more so. So one of the biggest things is you guys really do have a huge opportunity to make a profound impact on the patient, on the patient's family, and can really help the pediatric patient transition. When I say transition, end of life. So we're going to talk about the causes of infant and pediatric death. We're going to talk about appropriate communication between the patient, the family, the team. We're going to talk about being culturally competent, hospice care, how to do an assessment, and making sure that patients are adequately having their pain under control. The stages of grief from Emily Kubler-Ross, understanding the role of nursing education, and again, discussing the profound impact that you guys can have. It is amazing. And just 3 more objectives there. So lots of stuff we're talking about. This topic is one of the most important topics that we could ever go over. So when we think of death, we think of it, it is actually defined by your textbook as end of sustainable life. As you know, being pediatric, they're going to have a shortened lifespan. And typically, this is from either trauma or they can have physiological causes, such as non-accidental, which is your abuse or intentional self-harm, such as suicide. You can see physiological caused by forces within the body. You can see cancer, congenital defects such as Edwards syndrome. We've talked about some other syndromes that patients have a very shortened lifespan. We're going to talk about, we're going to look at routine nursing care in pediatrics differs from end-of-life care in your adults. Again, we want to make sure that the caregiver and the family are brought into the plan of care and treatment plans. And one of the biggest thing is you need to remember, you're not going to be curing these patients. So your goal is a peaceful death rather than the continuation of a healthy life. So communication with the patient and family is an essential role in, for end of life with kids. And really, when you're completing your assessments on the family, you're going to want to know how that family unit functions. Who is the major decision maker of the family? Who kind of holds the family together like glue? You're going to assess and need to understand the level of information that the family desires. If it's a medical family, they may want to know more what is going on medically as your pediatric patient is transitioning versus a person that is not medical. We probably should not go into any of those changes at all. So just assess and understand how much that patient's family should know. You're going to want to determine the cognitive level of family members. That's important. You're going to want to make sure that you're promoting safety. Remember that accidents and unintentional injuries are the leading cause of death in kids. The primary cause is SIDS, and this picture on the screen here shows exactly why. SIDS is the leading cause from kids 1 month to 1 year, but the peak time is 2 to 4 months, and that's published by the American Academy of Pediatrics. That parents and caregivers of newborns should be educated up to 1 year on Safe to Sleep campaigns, which is not co-sleeping, and placing the infant on the back to sleep. And you know, this picture here kind of shows how the airway can get compressed when the child is face down. Also, you know, a lot of times with co-sleeping, the parent may roll a little bit in the night, and maybe they're not rolling over, but when they shift their weight, it just causes the infant to get face down, or maybe their face is against the caregiver and they're just not getting that oxygen in, so can cause SIDS. One of the biggest new emerging SIDS prevention methods is providing the parents with a baby box that contains supplies. Once those supplies are removed, then the box can be used as a safe portable sleeping area. It has a firm mattress with a fitted sheet. And you know, if mom and dad want that baby right there, put the box in bed with them. Keep the baby in the box and put the box right there. So we talked about up to 1 year, leading cause of death is SIDS. Years 1 through 4, leading causes of death are unintentional injuries, such as your car accidents, abuse, things of that nature, congenital malformations, chromosomal abnormalities. Ages 5 to 14, leading cause of death is accidents, which are unintentional injuries, so can be, you know, car accidents, abuse still, cancer, intentional self-harm such as suicide. 15 through 19 years of age, again, leading causes of death are accidents, suicide, homicide. So it's really important to understand those causes of death and how we can mitigate those and educate the families for prevention. All accidents are preventable. Now, you may not be able to prevent a car accident, but if the child is restrained properly, whether it's an infant, whether it's a toddler, whether it's an adolescent in a seatbelt, they're going to have a much better chance than being unrestrained. Family-centered care, we kind of talked about that. We want to make sure that all of the families brought into the plan of care, we want to know what they understand is going on by assessing their level of knowledge and how much they want to know. That helps us to determine how much, you know, how much detail we can give. Just remember that we never want to lie to the patient or their family, but you may not go into full detail. And it's also very, very important to understand who can legally receive information about the family. Unfortunately, you are going to see whether it's bad divorces, whether it's just different family dynamics, but ultimately we can only give HIPAA-related information to the person that's designated as that not advocate, that is not the right word, but as the person that has the legal role as the caregiver. We want to make sure that we're given culturally appropriate communication. For instance, end-of-life care. Some cultures believe that you should leave a window open to let the spirit get out. If you don't, the spirit can remain trapped in the room. Some cultures want the patient to have last rites. So just be aware of whatever culture that your patient and their family has and try to honor that, especially if it doesn't coincide with your own personal thoughts. You need to honor their cultures and let them, because this is as much about the family as it is about the patient, and we want to help all family members and patients through this transition. Hospice care for peds is again an end of life to promote patient comfort and family involvement. It's typically within that last 6 months. Unfortunately, we see a lot of people that don't get referred to hospice until the last few days of life because, again, being pediatrics, their family wants to give, wants full treatment and patients to have the opportunity to try to be cured. So just make sure we're advocating that hospice really does promote patient comfort and family involvement. It is designed to promote a graceful, natural death rather than attempting to prevent the death with treatment. Also, another point I wanted to point out is hospice can occur inside the hospital. It can occur in a nursing home, and it can occur in home. One of the false beliefs on hospice is that it is only at home, but there's hospice care inside the hospital and nursing homes all the time. Initiation of hospice is generally done by the physician with the input of the care team. As a nurse, you are definitely able to recommend it when you see that there is a family and patient that would benefit. And most providers will listen to the nurse and actually rely on the nurse because they have more one-on-one time with the patient and their family than the provider does. You're going to serve as a patient and family advocate. The pharmacy is going to provide medications to increase comfort. You're going to want to make sure that nutrition provides the desired diet and food choices. Social work is going to be involved, ensuring that the family's non-medical needs such as housing, equipment, employer notifications so family can be off are all met. Chaplain or pastoral care focuses on the spiritual and religious needs. And child life specialists can provide age and developmentally appropriate toys. And then, of course, your physician is leads the care. There is an end-of-life nursing education consortium, and it's dedicated to excellence in hospice care. And that the whole goal of this project is to ensure that nurses are educated on hospice care and ensuring patients receive the highest quality care during the end of life. It provides nurses the knowledge and skills to positively impact the lives of patients and their caregivers. Pediatric pain control. This is huge. As our patients are ending end-of-life care, we want to make sure that they have pain control. And we have to remember that pediatric pain can manifest very differently than adult pain. They can have symptoms that are similar to adult pain symptoms, but they can have symptoms that are different. So you want to make sure that you're doing assessment techniques using vital signs, positioning, and caregiver input. Remember, your interventions can be pain medicine, and there can be other therapies to increase pain and decrease anxiety, promoting relaxation. You can do massage therapy, relaxation therapy, music therapy. You can do holding, positioning, complementary or alternative therapies such as healing touch or aromatherapy. Play therapy can distract the patient. And that child life specialist can help you determine appropriate activities such as puzzles or coloring. You need to make sure that you're utilizing an appropriate pain assessment tool. Remember, for neonates or infants, you can use the NIPS scale, NIPS. And so it looks at newborn's cry, facial expressions, respiratory pattern, position and flexion of the arms and legs, and the level of alertness. There's a FLAC scale, which is faces, legs, activity, cry, consolability for newborn to age 7. This looks at the patient's facial expression, leg positioning, flexion, activity level, crying level, and consolability. And when we talk about positioning, is the patient drawn up and stiff and tense, or are they relaxed? The FACES scale is age 3 and up. You have to remember that to use the FACES scale, the child has to be developmentally able to read and understand the faces. And then you just ask the patient which face is how they're feeling, whether it's a crying face or a sad face or a happy face. There is the visual analog scale that's age 7 and up. And then there is the traditional pain scale. So lots of different scales. Really look and see what is your facility's preference. There's not necessarily one better than the other. It's more about consistency. You don't want to ask a different pain scale than the nurse that was on the prior shift. That can be confusing for the patient as well as the caregivers. Medicine administration. You always want to do the least invasive administration route, from topical, oral, IV, inhaled, rectal. We do try to keep the kid free of most invasive devices at the time of death. So for instance, morphine, we often give morphine IV. However, if as death is nearing, if the patient doesn't have an IV line, you can give it oral as a liquid placed in the buccal cavity, which is the inside of the cheek. It can be given as a topical patch, and it can also be given as a nebulizer, as inhalation, so that the patient doesn't have to be poked again for an IV stick. Cultural and religious considerations, we kind of talked about that a minute ago, but again, just make sure that you're respecting the cultural beliefs. You want to provide culturally competent care. Child development. It's really important for us as nurses to understand the overall child development, where they're at, and their developmental level and their view of death. This is important to provide competent care. Again, we don't want to be talking below or above their educational level or understanding knowledge. So for instance, a kid could be 7 or 8, but if they have a congenital condition or disease, their developmental level may be lower than the expected age. So really you need to do an appropriate assessment to see where they're at. That way you can effectively communicate with them as well as the family. There is a really good chart in your book that kind of talks about expected behavior. And so it's important just to understand all of these things. There are many theories on grief. The one that's probably the most common is Emily Kubler-Ross's. But basically almost all theories talk about how individuals progress through their grief, and they're all on an individual timeline. The Common Stages of Grief by Kubler-Ross, which is probably one of my favorites just because she is the most well-known, and I think she does it the stages of grief are very well. But anticipatory grief, and this occurs before the stages of grief and is common in infant and pediatric death. And that's when the family of the patient prepares for death before the dying process actually starts. We have denial, and following anticipatory grief is denial, which is refusal to believe that an infant or child is dead or dying. We have anger, and that's where, the caregiver or the patient can be mad at the world. They have feelings of wrath or indignation, and it often manifests as anger towards the disease. It can be anger towards the cause of the death. It could be anger towards the medical staff or caregivers. Bargaining or negotiation, this is an attempt to create a change in the situation through an agreement for services. And this can even be like your family that was not religious and becoming religious, bargaining with God that if they save the child, they'll start attending church. But this can go back to the anger stage. If the child, then passes, then they're angry with God because they weren't saved. And that's just one particular example. There are lots of examples out there. Depression or depressed mood is the next stage, and this manifests as a loss of interest in life and normal activities, along with feelings of guilt or self-worth. And then we have the stages of acceptance, and this is where they accept to receive or grieve what is often. The family and the patient comes to terms with the anticipated loss. Remember, family members may grieve at different stages, and not everyone grieves in the same manner at the same time. One of the biggest things I saw is with a stillborn death. A lot of people don't understand why the caregiver wants to show off the baby. You have to remember that mom has carried this baby in womb for the last 40 weeks or 36 weeks, and the baby may be in NICU, so the family may have never got to see a baby, and so the funeral is the chance for her to show off. And a lot of people will find that weird, but then when you stop and think about what mom is going through, it's not weird. Everyone grieves differently. And again, it's up to us as nurses to provide that culturally competent care, see where all the caregiver and family members are, and help them go through these stages. As a staff member, it's also common to feel the loss of a patient, and so just make sure that if you find yourself sad, it's okay. You will see nurses that will shed a few tears, but even though you're upset, remember that it is your job to help take care of the family and patient immediately post-death. You may need to step out of the room, excuse yourself, kind of get it together before you come back. And I don't necessarily think it's a bad thing if you do shed just a few tears and the patient's family sees that as that makes you more normal. It normalizes things for them, but you should not be in front of them anguish crying. There's a difference between shedding a few tears, being there for the patient's family, and being inconsolable yourself. Which of the following stages of Kubler-Ross theory on grief is defined correctly? So is it bargaining to receive or grieve what is offered, coming to terms with the event and the associated loss? Is it depression, a refusal to believe that an infant is dying or dead? Anger, an attempt to create a change in the situation through an agreement for services anticipated? Or is it anticipatory grief, and that's where the family of the patient with a terminal diagnosis prepares for the death prior to the dying process? The correct answer is D. Anticipatory grief occurs before the other stages of grief and is common in infant and pediatric death. And this is where the family of the patient with a terminal diagnosis prepares for death prior to the dying process. Education for the patient and the family should be explanation of cause for the terminal diagnosis and how the disease will cause death. Again, make sure that you're doing it in their terms and how much they want to receive. Explanation of current medical interventions are needed and what the patient and their family should expect. Explanation of the dying process, of what to expect. And parent and caregiver education should always include how the disease process will affect the child, current medical treatments available, all available options, potential disease outcomes with discussion of time frame when possible, what to expect during the dying process in terms it's appropriate for the family, especially siblings, parents, caregivers, and just remember that every child's death experience will be unique based on the underlying diagnosis. Ensure that the family members are educated on the decline as it's occurring, the physical changes such as being cool, mottled, skin changes, swelling, altered verbalization, swallowing, breathing pattern, and altered state of consciousness. What to expect at the time of death, such as how the child will look. What to expect after death, such as care and disposition of the body and funeral arrangements. Withdrawal of care, that occurs when the family decides to stop all life-saving measures and allow the infant or child to die naturally with the family at the bedside rather than attempted resuscitation. Parental rights and withdrawal of care allow them to consent to end interventions and determine when the intervention should stop. They also have the right to change their minds and continue care. Initiation of withdrawal care is determined by the condition of the patient, the physician's opinion, and the parent caregiver desires. Nursing interventions and withdrawal of care should be turning off the monitor, disconnecting all invasive lines, and creating a comfortable, undisturbed, peaceful, and private environment for the patient. Family present in code situations are different, so you need to make sure that you know your facility's protocol. All of the latest research recommends it. However, if you have if your facility protocols does not allow it, that's different. But you can advocate in your facility, not in front of the patient, not in front of the patient's family, but on a policy level, you can advocate to change those. And, the desired outcome of having the family in a code situation is so that they can understand and have communication, decrease confusion on what's going on with that patient and how the family can really have that positive benefits because they know absolutely everything was done to save the patient. Now, the negative parts of that is the family sees the child in the worst situation possible. And it can be very distressing. So if you're going to have the family members present during a code situation with the pediatric, you do need to make sure and have a chaplain there, as well as a nurse needs to be assigned to be able to explain what's going on. And so you will see some facilities that don't do this just because of not having the adequate personnel. We just kind of talked about code situations. We've talked about stopping all life-saving measures. We talked about parental rights and parent and family education. Family involvement in the daily nursing care of the dying child will be different for all families depending on the family dynamics. But when family desires and it's appropriate, they should be involved in all aspects. Remember, especially a caregiver may want to assist with bathing and dressing of the infant or child. They may not want to be involved in bathing, but they want to be involved in picking out the clothes. So accommodating visitors despite unit visitation rules is the role of the nurse and should be done appropriately while respecting the unit and the other patients, but allowing that transition of the patient and the patient's family. Remember, again, you want to have the pastoral care or chaplain there. Most facilities have a non-denominational chaplain, so it doesn't matter what religion they are, that they can be assisted. You want to allow the family to say goodbye to the child and spend some alone time with them. And, you know, if it's possible and desired, sometimes the family wants to hold the child or lay in the bed next to the child. Creation of mementos and keepsakes for the family is also important, such as handprints, footprints, using molds or ink, a lock of hair cut in a secure envelope, pictures. So very, very common, and we definitely want to support that because it does help the family. You want to make sure you're following your hospital protocol for once the death does occur and that the patient is declared dead, as well as the disposition of the body. You know, are they going to your facility's morgue? Do they stay in the room until the funeral home or coroner come? You want to make sure and properly label the body and respect the body at all times. Some patients do require an autopsy, but will be at the discretion of the local coroner. So just follow your facility protocols and know what those are. Which of the following is true about family presence during a code situation? A, family should never be involved in pediatric codes. B, family present can be positive since the family knows absolutely everything was done. C, family members are not likely to attempt to be at the bedside. Or D, the desired outcome is for the family. I can't read all of D. I'm sorry, my picture's in the way. The correct answer is B, though. Family presence in P code situations are handled differently in all hospitals, so make sure you know your facility protocols. When they are allowed to be there, there are positive and negative consequences. And one of the positives is that the family sees that everything was done. Just make sure you have that chaplain there to be supportive of the family, and make sure you have a nurse assigned to them to discuss and describe what's going on. Organ donation is the giving of viable organs from a dying patient to patients in need of specific organs. Pediatrics is no different. Pediatric organs can be transplanted into adult or pediatric patients. And they can do that as long as their organs are not damaged by disease, trauma, or medication. So when this happens, you're going to have protocols into place that the family is approached by an organ donation team to discuss it. They are specially trained in approaching families to request donation of the organs. Consent is needed from legal guardians. Once consent is given, blood is drawn from the patient to determine the patient on the transplant list who are the best match. Procurement of organs is done by the transplanting surgical team, and often they will fly in and do the surgery themselves. In the operating room, the patient and family members should say goodbye to the patient before the transfer to the operating room, because the patient does die inside the operating room. You know, we should educate that the patient will be kept alive via medical intervention until the procurement surgeon arrives. Details of how the infant or child will pass away in the operating room, and that the family cannot be in the operating room, and they should be educated on the benefits of organ donation. OPTN is an Organ Procurement Transplant Network, and this is a unified transplant network established by U.S. Congress in 1984, and it oversees the federal laws related to organ donation and procurement. They have an organ matching and placement through a computer system, and they have a fully staffed organ center operating 24 hours a day, 7 days a week. Organ donation is a closed process, so the donating family will not know who has received their child's organs. It's a responsibility of the nurse to understand and adhere to the nursing scope of practice. When caring for a peds dying patient, you must understand the legal aspects, including determining the legal guardian, obtaining consent, withdrawal of care. The Nursing Practice Act of each individual state guides nursing practice, and these acts can be different state to state. So make sure that you're aware of your states. Autopsies can be requested by the family, the physician, or the coroner. Families may request an autopsy if they wish to know the exact cause of death. However, if the coroner does not agree that an autopsy needs to be performed, the family may be responsible for the cost of the autopsy. If a physician wants an autopsy and the coroner does not agree with the need for an autopsy, the family may need to give consent. However, the coroner has a legal right to request an autopsy in any suspicious or unexpected death and does not need the consent of the family if it is considered legally needed. DNRs, some kiddos, especially terminal, will have a DNR order just like adults. So you want to make sure that you understand your facility protocols and that you honor this. DNR orders can be different. Some may just say they don't want CPR. Some may say they don't want CPR or a feeding tube. So all kinds of different things. So you need to make sure and know what the DNR order is. You need to make sure and know what your facility's DNR order is. And you need to make sure on a kid that the legal guardian is the one who signed, who is able to give consent for the DNR. So for instance, you know, if maybe the state has stepped in and removed guardianship from the parents due to potential abuse. So if so, mom or dad is not able to say, you know, is not able to determine DNR orders and things of that nature. So lots of different stuff here. End of life care is hard. It takes a special nurse, and kudos if you are going to be that nurse. You guys have a profound influence on these patients and their families and really can help this transition. And I can't say enough of good about it. I unfortunately was someone that did not care to be this type of nurse. So I deeply respect all of you that are. I hope you have a great day, and if you have any questions, don't hesitate to let me know.